Hi everyone, my name is Holly. I'm a research fellow at University of Manchester, and I'd just like to share with you, sorry, I'm just going to bring up share screen, and I'd just like to share with you a presentation talking about a really exciting research project that we're doing. For some people, it might not be relevant to you, but you might know somebody who would be willing to take part. So the study is called Prominent. It's an international study, and we know that for people living with obesity, they have a higher risk of developing certain types of cancer. And what we want to find out from the study is, does weight loss from bariatric surgery reduce your risk of getting these certain types of cancer? So who can take part? Well, taking part is voluntary. You don't have to take part if you don't want to. But if you're interested, then I need you to be able to say yes to all of these. You need to have a uterus and breast tissue. You need to be over the age of 18 years old. You need to have never had cancer diagnosis before. You need to not be pregnant or planning pregnancy in the next 12 months, and I'll explain why that is. And you need to be having bariatric surgery, so you need to be tier 4. So what will you be asked to do if you do decide to take part? Well, you'll be asked to complete a series of questionnaires looking at food habits, looking at general health, medications you take, etc. And you'll also have to have quite a large number of samples taken. These include blood tests, they include mouth swabs, swabs from the vagina, swabs from the anus, and then tissue samples, so little pieces of tissue taken from the bowel, the womb, and from the breast. And we'll also do some measurements of your height, your weight, and your hip circumference. These measurements will be taken before you have your weight loss surgery, and then they'll be repeated 12 months after your surgery. If you decide to take part, where will you go for those? Well, you come to St Mary's for the vast majority of the samples, and then you'll need to go to Wythenshawe for the breast sample. And there's a small possibility you might have to do a poo sample at home, but that's it may be possible for us to take it when you come to your St Mary's appointment. The benefits, well, we're going to be checking the samples from the womb. When we take the bowel samples, we'll be having a direct look at the bowel, and also the breast samples taken using an ultrasound. So again, we're checking all of these to see if there's any abnormality. So there's a little bit of screening involved for you. But also this is going to hopefully benefit your friends, your family, and other people as we find new ways to prevent cancer. As I said, if you decide not to take part, then nothing changes in your care that you receive from the team at Salford. The study is completely voluntary. We understand that this is quite a lot to have done and quite a number of samples to have taken. So we'd like to reimburse you for your time and expenses. And you'd get £25 for each visit, with a total of 4 visits being £100 between the first appointments that you have and then the appointments 12 months later, and £50 for each of the biopsies that you have, totaling £300 for 6 biopsies, again, beginning of the study and 12 months later. And then at the 12 months, you also get an additional £100 study completion fee for all samples. As I said, I'm a women's health doctor, a research fellow at the University of Manchester, and I'll be one of the contacts for the study along with the team at Salford. And I will be taking the samples from you and being your person to contact. So I'd really like to work with you all. And if you have met the team at Salford and you think you'd like to take part, then please send me an email. I'll just give a second for that address there. So it's prominent@manchester.ac.uk. And if you send an email, we have just had ethical approval finalized for the study. So I'll be able to get in contact with you from that email address to give you more information if you'd like it. And I'll also put that email address in the chat. So I'm going to stop sharing now. And thank you to Stevie, thank you to Mr. Alkafaf for your time, and I look forward to working with some of you in future.
Thanks very much, Holly. If you want to send that email across, I'll pop it in the email that goes out after the webinar as well, so people have got access to it outside of the chat. Brilliant, thank you for that, Holly. So I'd like to welcome Mr. Alkafaf now to talk to us all about bariatric surgery. And remember, if you've got any questions, pop them in the Q&A and we'll come to them at the end of the presentation.
Right, thank you, Stevie. Let me just start my presentation. I can see we've already had some questions, so that's good. People are poised and ready. Right. Share. Is that coming up on the screen now?
That is, yeah, you're good to go.
Very good. Right. So tonight we will be talking about bariatric surgery. My name is Bilal Al-Kafaf. I am a consultant surgeon based over at Salford Royal. And we'll be talking about not only bariatric surgery, we'll give a little overview on obesity, how it develops, what it is exactly, why it's so important to treat. And then we'll also spend a little bit of time talking about some of the fears that people have in relation to bariatric surgery. The majority of the evening is going to be spent answering your questions. So if you do have any questions for me, make sure you put them in the Q&A section so Stevie can monitor those throughout the talk. And I'll try and answer as many of these as possible. Usually that part of the session can go on for a long time, but we'll try and answer as many of your questions as we possibly can. Right, so obesity and its impacts we'll be talking about, the NHS treatment options, so the options that are specifically provided and are undertaken by us at Salford Royal in the NHS setting. We'll talk about those, the biggest fears, and of course the questions. So obesity is the excessive accumulation of fat, which importantly poses a risk to your health. Now, we know that obesity is linked and associated to well over 200 medical conditions. We'll talk about some of those now. We also know that our understanding of obesity has changed significantly over the last 10, 20 years. We now recognize it as a chronic, relapsing, and progressive condition. What that means is it doesn't happen overnight. It is something that happens gradually often over many years. And even if you have control over your weight, there's a possibility that weight can come back on later on in life. And that's a really important consideration when it comes to understanding the condition of obesity, because it also impacts on our understanding of how some of these treatments work, which we'll touch upon shortly. Obesity affects approximately 1 in 4 adults in the UK, and 2/3 of people either have obesity or are overweight. Now, more worryingly, about 1 in 4 children under the age of 15 are either obese or fulfill the criteria of being overweight. So this isn't a problem that's going to go away anytime soon. There are wider social implications. So we know that the direct costs as a result of obesity to the National Health Service is around £6 billion every single year. And if we then begin to explore some of the wider implications on society, when we look at sick days and some of these other factors, the impact on the wider economy, we're probably talking of an estimate around £30 billion every single year. So it's really important, not just from a financial perspective, but from a wider social implication, that we try to prevent obesity. And then, of course, those who have developed obesity, we try and help people out and try to help them control their weight and reverse many of the medical conditions we'll be talking about shortly. So obesity harms health on an individual basis. We've touched upon the fact that it is associated with over 200 weight-related medical conditions. Some of these are on screen in front of you. So if we look at these: heart disease, liver disease, stroke, asthma, back pain, sleep apnea. It also affects your mental health. So depression and anxiety and some other mental health disorders are directly linked to obesity. We also know that cancer is linked to obesity. There are 13 types of cancer and probably a lot more that are directly linked to obesity. And in some instances, for example, endometrial cancer, if we treat obesity, a lot of the time, endometrial cancer, certainly the precancerous cells, can go into remission and not actually progress into cancer. And that is some of the work that has been done by our very own colleagues in gynecology and in women's health here in Manchester. You heard Holly Baker-Rand already this evening talk briefly about some of the studies that we're doing. So these are very, very important associations that we are actively involved in researching as we speak. We've talked about some of the financial implications on wider society, and we've talked about the individual medical issues that obesity is linked with. But the reality is that there is also a lot of stigma associated with obesity, and this therefore impacts on the quality of life and the social aspects on an individual basis. We know that people who struggle with their weight are less likely to be in employment, but also can be passed up on opportunities at work as well. We know that people with obesity face widespread discrimination and stigmatization, and these are added reasons for us to really try and treat obesity as best as we can. Let's now move on to the treatment options. In broad terms, there are four considerations when we talk about how we treat obesity. All of these options, certainly when it comes to invasive treatments or medical treatments, must be accompanied with the commitment by the individual to engage in lifestyle changes, changes to nutrition, changes in physical activity levels. And we'll talk about that briefly in due course and in the Q&A session. When I speak to patients in clinic, I will always tell them that the first option that they have is that they do nothing at all. And why is that important? Well, everyone needs to understand their options, the pros and cons of each of the different treatment options, including the option of doing nothing. Now, that is the only option that's going to completely avoid the very small risks associated with some of these treatments. However, there is a consequence and there is an implication of doing nothing, which is that a lot of the medical conditions that people may already have can get worse. And of course, if you don't have medical conditions related to obesity, these can develop. That's why when we talk to people in clinic, we also spend a lot of time talking to them about their family history, understanding some of the diseases that run in the family. And that's something, again, we can talk about later. When we discuss treatment options in clinic, broadly speaking, there are the medical weight management options, which involve some of the new injectable medications that have been out on the market over the last couple of years. There are endoscopic treatments available, which include the gastric balloon and some newer novel treatments, including the endoscopic sleeve gastroplasty, which involves us using a camera and sutures or stitches, internal stitches, to make the stomach smaller. That's something that is still being developed and has been adopted by NICE, which is the National Institute of Health and Clinical Excellence, as an NHS treatment, but not very many centres are providing or offering that. Where we certainly focus our treatment options at Salford is in the surgical side of things. And we'll be talking more about the surgical options in the next few minutes. Before we touch upon that, let's talk about the eligibility criteria, because that's really important. Traditionally, the eligibility criteria have focused primarily on this calculation called the body mass index. The BMI, or body mass index, is a calculation which takes into account your weight in relation to your height. In an ideal world, a healthy BMI should be anywhere between 18.5 and 25. If you have a BMI of greater than 40, then you are automatically eligible for bariatric surgery. If you have a BMI of 35 with a medical condition associated with obesity, which would benefit from treatment, then you are eligible. And there are certain circumstances, for example, if you have new onset diabetes in the last 5 to 10 years, then your eligibility criteria is reduced. And further still, it can be reduced if your ethnic background is of South Asian origin, as we know that the risk of developing these serious obesity-related health conditions such as type 2 diabetes occur at a much lower level in that patient population. However, these are the traditional established guidelines, when in reality, these guidelines are moving sands. We have had over the last 12 to 18 months new guidelines from international consensus groups and international associations, which suggest that actually bariatric surgery can be considered and is safe at a much lower body mass index. So we've all heard these stories of people going abroad or people being turned away and saying, actually, you're not heavy enough. Well, we think that that is absolutely absurd. People who are BMI of 34 and being told, sorry, you don't fulfill the criteria, even though we know from their past medical history that that weight has severely impacted not just on physical, but also their mental health. It's, to me, certainly it's absurd that we would turn somebody away when we have such effective and powerful treatments to help reverse many of these ailments and conditions that they have. Now, how does bariatric surgery work? It's really important for us to spend a little bit of time talking about this, because in the wider population, people often think of bariatric surgery as an easy fix or an easy way out. People also think that bariatric surgery works primarily just by shrinking the stomach and reducing the amount of food that you can eat and drink. And whilst that's partly how it works, it's certainly nowhere near the full story. Quite often you'd hear people saying, well, you know, if all you're doing is reducing the size of your stomach so that you're eating less, why don't you have the willpower to do it yourself? Or what's the difference between that and just going on a very low calorie diet? And the reality is that there is a big difference. When we compare two individuals, somebody who's had a gastric sleeve or a gastric bypass or a mini gastric bypass, to somebody who has just been on a very low calorie diet, we know that even though they might be eating the same number of calories, in reality, the person who's had the surgery will have more profound weight loss and more sustainable weight loss in the longer term. We know these very low calorie diets don't last or are not sustainable for more than a number of weeks before then people revert back to their old eating habits, and that results in significant weight regain. One of the things that we talk quite openly about is the fact that these types of treatments offer a different approach to weight loss. It gives us access to different pathways for weight loss as well. The sleeve gastrectomy and the gastric bypass, not only does it reduce your portion sizes because your stomach's smaller, but it also results in significant reductions in appetite and also changes to the pathway from the gut to the brain, which modulates and regulates your metabolism. So those changes in combination, and this is important, in combination with making the right lifestyle changes with respect to diet and with respect to physical activity, is what results in the significant weight loss and sustained weight loss in the longer term. Now, finally, one thing that is often overlooked is the importance of the brain space which comes along with some of these procedures. Quite often when I speak to people in clinic and I speak to them about how long they've struggled with their health and their weight, the overarching story is a daily struggle with their weight and a daily struggle or a daily unhealthy association with diet and food and yo-yo dieting and wondering which diet they're going to be doing this week and which, you know, how much weight have they lost. And there's often there's a lot of background noise that comes along with obesity and struggling with weight loss and weight regain. And that can be quite heavily imprinted in somebody's psyche. If you can imagine over many years and sometimes decades, someone's been struggling with their weight, it's not unusual and it's completely understandable that there's often a lot of background noise with respect to the journey or their day-to-day life. What bariatric surgery offers is almost a clarity, because within that first 12 to 18 months that people have their surgery, people will lose a significant amount of weight. And that results in a positive motivation and a positive approach then to being able to move more freely because they're losing more weight. They're able to lose more freely and therefore able to engage in physical activity. And then in addition to that, the motivation that comes from seeing those positive changes also then leads on to healthier food choices. And that's primarily because when you put the effort in, you see the results. And that's often not been the case up to that point. The sleeve gastrectomy is the first procedure that we're going to talk about this evening. It is by far and away the most commonly performed procedure anywhere on the face of this planet. It was developed approximately 25 years ago, and initially was used as the first stage of a two-stage procedure. Well, actually what we found is by just doing that first stage of that procedure, just focusing on the sleeve gastrectomy, people were losing a significant amount of weight and were able to keep it off. The technique of the sleeve gastrectomy has certainly evolved and developed over the last 10 to 15 years, and that has enabled us to provide that as a standalone procedure, which is effective and results in sustainable weight loss when we, of course, combine it with some of those healthy lifestyle changes that we've talked about. The sleeve gastrectomy involves us removing part of the stomach, including the part that makes you feel hungry. So by doing that, we reduce portion sizes, we reduce appetite, and of course, some of those pathway changes, the links between the gut and the brain, that changes and results in changes in metabolism, which then will lead on to the profound weight loss. It's permanent. It results in us physically removing that part of the stomach. For most people, they can come into the hospital, they stay in overnight, they're home within, they stay in overnight, they go home the following day, and most people are fully recovered by about 2 weeks from a physical perspective. As you're probably all aware, and perhaps we'll talk about this in the Q&A session, the post-operative recovery in terms of the phases of diet, the fluid moving on to the pureed and then normal foods usually takes anywhere from about 6 to 8 weeks. The next procedure is something called the gastric bypass or the full gastric bypass. The full title, full medical title, is the Roux-en-Y gastric bypass. It is the gold standard procedure for bariatric surgery. It's the one that we've been doing for the longest. We've been offering the Roux-en-Y gastric bypass for over 60 years now. It started off as open surgery, of course, and it's been developed and refined over the decades so that we now are in an era now where the Roux-en-Y gastric bypass has been performed in a standard fashion for several decades, if I'm going to be honest. It involves making a small pouch out of the top of the stomach, no bigger than the size of your thumb. And then what we do is we cut part of the intestine, as we can see on the screen, and we join that to the stomach pouch. So the grayed out bit is the part of the stomach and the first part of the intestine, which is bypassed. So the food bypasses that part of the stomach and the intestine and the gastrointestinal tract. So the procedure works by reducing portion sizes because your stomach's a lot smaller, reducing appetite and hunger in a slightly different mechanism than that to the sleeve gastrectomy. It also results in those powerful changes to the pathways between the gut and the brain. And finally, because part of the food which is being consumed is bypassing part of the gastrointestinal tract, there is an element of malabsorption. So some of the calories that would have ordinarily been absorbed, or some of the foods and nutrients that would have been absorbed from the stomach or from the first part of the gut, that does not happen. So part of it is also a malabsorptive effect. Again, in combination with diet and exercise and physical activity, that results in significant weight loss. Finally, the mini gastric bypass or the single anastomosis gastric bypass is a relatively new contender in the field of bariatric surgery. It was developed around 10 or 15 years ago in the United States as an approach to make the bypass a less technically challenging procedure. So instead of having 2 joins, which is the case with the gastric bypass or the full gastric bypass, now what we're doing is only needing 1 join. And the other thing about this type of procedure is that the gastric pouch or the stomach pouch that we're making is a slightly different shape. You might notice when we compare the full gastric bypass on the screen that the pouch is small and it's short, whereas with the mini gastric bypass, the pouch is longer and narrow, and it's almost like a halfway house between a sleeve and a gastric bypass. Now, why is that important? Well, because the join that we're having to make is lower down. That means the tension that we create by bringing the bowel up to the stomach pouch is reduced. And often when we are faced with a scenario where a patient would particularly need a gastric bypass type procedure, and we'll talk about that in a second, then when somebody is larger and they need a gastric bypass procedure, it can be very challenging, technically challenging, and that then exposes people to a degree of risk, especially with healing, to bring up that bowel to the stomach pouch. Whereas in this scenario, it is easier to bring that bowel up to the stomach pouch, and therefore the complications rate should be lower in that particular scenario. Now, whilst it's called a mini gastric bypass, it is by no means mini. It's in its effect. It results in very similar outcomes and results to the full gastric bypass. And whilst this has only been around for 10 or 15 years, and certainly hasn't been very popular up until the last 5 or 10 years, and therefore we don't have longer term results, and that's one of the downsides of the mini bypass. Certainly the short and the medium term results are looking very positive. So let's now move on to some of the fears around bariatric surgery before we then move on to your questions. Number one fear is, am I going to die? And that is related to a broader concern regarding complications and risk. The first thing I want to reassure you is that the risk of developing a serious complication which results in death is actually very, very small. The risk is around 1 in 2,000. It's probably less than that. We know that figure quite accurately, certainly in the UK, because we all have to submit our data to a national registry, and that registry gets updated on a weekly basis and gets emailed out to the bariatric surgeons up and down the country. And in fact, I've only just received my report today, which I've reviewed. So these are accurate figures. When we compare that to, say, another procedure such as the cholecystectomy or removal of the gallbladder, or even having your joint changed or replaced, then we know that the risk of bariatric surgery is actually less than those other types of procedures. You may be shocked to hear. So it's actually a very safe procedure, and it's one that, of course, we carry out on a regular basis. The other risk that people worry about is the risk of leak. So the leak is the phenomenon which occurs when the staple line or the surgical joins that we make during our procedures, they don't heal properly. And what happens is your saliva and your food and drink then leaks out of that defect, and it can make you very poorly. If that happens, you will need additional treatment to fix that and sort that out. But the risk of that happening is very, very small. Now, there is an umbrella complication rate, which takes into account all other issues that can arise and that may need some additional treatment and investigation. And that usually is less than 5% for the gastric bypass and less than 3% for the gastric sleeve. People often worry about the amount of pain that they're going to be in. Well, you have to bear in mind that this is keyhole surgery. And as a result of that, we introduce gas into the belly in order for us to be able to see things a bit more clearly. That gas can irritate the diaphragm, can irritate the lining of the abdomen, and that can result in what we call gas pain. The other thing is, with respect to the wounds, we use keyhole surgery incisions, and therefore the impact of that is certainly significantly less than it would have been in the past when we used to do open surgery. As I've said before, physical recovery usually takes a week, but importantly, expectation is key. So whilst I've talked to you about some of the discomfort that you might have after surgery, you should also be aware that on the day of your operation, you will be expected to be up on your feet. You'll be expected to be drinking, looking after yourself, mobilizing to the toilet, such that the day after surgery, you should be then moving more freely, drinking more freely, and be ready to be discharged home. When you get home, it's not about laying in bed for the next 2 weeks. We want you up and about, hydrating yourself properly, reducing those risks of complications such as clots to the legs, etc., so that you can make a full recovery. Most people are back to work within a couple of weeks, and most people are driving within a couple of weeks as well. These are some of the typical incisions, certainly for my patients. People will have 4 or 5 incisions made, and this is commonly where I would make the incisions for my patients. In the recovery period, when we're talking about pain, there are certain expectations that you would want to see pain gradually reducing as the days progress. If you then develop sudden severe pain, either in the belly or in the chest, you must seek immediate and urgent support and medical attention. Now, another fear that people have is it going to work? What if it fails? And you can imagine that is a really common fear that people have. And it's an understandable fear. As we've talked about before, you've had years and decades of up and down, yo-yo dieting, success and failure. In the psyche of somebody who's lived that journey and lived that experience, you will naturally have that fear of failure etched within you. And the key thing that you have to bear in mind is that everybody will lose weight with this surgery. However, the degree of weight loss that occurs very much depends on a number of factors, including the degree to which you adopt those healthy lifestyle choices that we talked about, your age, whether you're having revision surgery, and some of the other factors such as your physiology and biology. Let me just switch my phone off so that we're not disturbed. Okay. When we look at weight loss trends during the first 6, 12, and 18 months, the first phase, which is the rapid phase of weight loss, usually occurs within the first 6 months. Even within that rapid decline in weight, there will be ups and downs, so that there will be variation. And everybody's trend or pattern of weight loss varies significantly. So you may struggle with a stall where you plateau and you don't lose any weight for a couple of weeks. And that can certainly frighten people. Has the operation stopped working? Am I going to fail? Am I going to, is it going to get going again? I've invested so much time and effort in weight loss and going down this journey, and I've only lost so much weight. It's key to understand that these fears are really normal, and the stalls are also really normal. The other thing to bear in mind when we talk about success and failure, although I don't like to use those words, but success certainly isn't just focusing on the number on the scales at the end of the 12 or 18-month period, but you need to be judging success of these types of procedures in other terms as well. Has it resulted in an improvement into your health and quality of life? Has it resulted in reversal of a lot of the medical conditions that people complain of and have to take medications for? Not only do we have to think about weight, but look at measurements as well. Whilst you might be stalling, you have to realize that there are other physiological and biological changes undertaking during or happening in your body during that process. So you might be losing inches rather than kilos or pounds on the scale. So these are things that you need to be mindful of. The last thing that I would say is do not compare yourself to other people. Comparison is the thief of joy, as they say, and you are on your own journey. You have your own set of circumstances, your own genetics, your own physiology, your own commitment to making those lifestyle changes. And so naturally, the impact that those factors have will be relevant to you and not relevant to other people. You have to also bear in mind that not everything that you read online is true, and just keep that in mind. Focus on your own journey and your own path. And when you are anxious about things not going right, or you feel that you need some additional support, that is why we are here. That's the importance of aftercare and support from the dietitians, from the bariatric nurses, from the psychotherapists, and from the surgical team as well. People often worry about weight regain after weight loss. So it might not just be that they've not lost enough, but you actually lose enough and then begin to regain weight. And that's another fear born out of that yo-yo dieting cycle that we've seen over many years and decades in patients. The broad understanding is that if we take 10 patients who've had bariatric surgery, 7 out of 10 of them will lose weight, will keep it off for a sustainable, for the sustainable longer term. 2 out of 10 people will lose a significant amount of weight, but will also regain some of that weight. And 1 out of 10 people, we believe, will lose all of the weight and regain all of the weight as well. Now, that might be a shocking statistic, but it really does underpin and underline the importance of engaging with aftercare, making sure that we've addressed all the underlying factors which contributed to weight gain in the first place, so that they don't creep back in the future and cause you to risk weight regain. Having said that, some people will naturally regain weight, and there are now newer approaches to managing weight regain, which we can talk about later. The other concern is, are you ever going to enjoy food again? The short answer is yes, but you will be enjoying food in a slightly different way. We've already talked about the diet after your operation. You'll be going through liquid phase, pureed foods, soft foods, and then normal diet, usually by about 6 to 8 weeks. But there are other considerations as well. Alcohol and fizzy drinks. Quite often people worry about them because they're being told, or they've read, that actually it results in stretching of the stomach, stretching of the sleeve, and that unfortunately is a bit of an old wives' tale. The reason that I don't encourage people to drink alcohol and fizzy drinks is they've got absolutely zero nutritional value to them. If you imagine you're going to have a very small stomach, your nutritional input is going to be significantly reduced, and therefore we need to prioritize good nutrition after surgery. That means good hydration. That means, in addition, prioritizing your protein, your fiber, your good fats and healthy fats, and then your complex carbohydrates in that order. If you do that, you're not going to have time or space for fizzy pop or drinks full of sweeteners and chemicals, or alcohol, in fact. In addition, with alcohol, we know that people are less tolerant of alcohol when they're drinking after bariatric surgery. So you not only will get more tipsy and drunk more quickly, but alcohol stays in the system longer than previously. So you need to bear that in mind. People can also develop new intolerances and differences in taste perceptions. And finally, let's talk about loose skin, because that's something that terribly affects people, or affects people's decision-making process, and certainly is a big fear. Again, let me go back to expectations. Expectations are absolutely key. The more weight you lose, the more loose skin you're going to have. The older you are, or the more sun exposed you are, or if you're a smoker, you are more likely to have loose skin. The question that I always ask people in response to the question that they have of whether they'll have loose skin is having loose skin enough of a reason for you not to consider bariatric surgery or weight loss surgery, and the positive impacts that it will have? And the answer is almost certainly absolutely not. They're still happy to go ahead with bariatric surgery, but they just more want to be aware of what can they do to minimize the effects of loose skin. So some of these things that you should certainly focus on is make sure that you hydrate yourself well, make sure that you're taking your proteins and your multivitamins, making sure that you're building muscle to give your body a scaffold and some shape. We know, as we've talked about, you can't do anything about your age. You can do something about smoking, and you can do something about sun exposure as well. But the reality is that most people will have some loose skin, particularly in the NHS, where we tend to only put through people who are absolutely really struggling with their weight, and certainly have a higher BMI. So the more weight loss you've got to achieve, the more loose skin you're likely to have. The good news is, however, there is a remedy, or there is some treatment that you can have for loose skin, and some of these can be absolutely phenomenal. Some of these examples are placed on the screen here for you to see. Abdominoplasties, 360 contouring, certainly reconstruction of the chest, not just for women, but also for men. And of course, the areas under the arms and the thighs, you can really have a significant impact. What I would say to you is two things with regards to plastic surgery. Number one, well, actually three things. Number one, it's very rarely available on the NHS anymore, so you would likely have to fund that yourself. Number two, wait until at least 18 to 24 months after surgery to make sure that you have absolutely lost as much as you're going to wait, to make sure that you've lost absolutely as much as you're going to lose, but also to make sure that your nutritional levels have recovered and that your blood tests show that your nutritional levels are within normal limits. And finally, if you are going to go and consider plastic surgery, make sure that the person who you are considering, and you should certainly speak to more than one person, has experience in plastic surgery following bariatric and weight loss surgery, because the skin and the impact on nutrition results in a difference in the type of tissues. It can sometimes lead to an increase in infection rate, of wound infection rate, and you really need somebody with an experience in dealing with this subspecialty of contouring or plastic surgery after bariatric surgery. So in summary, weight loss surgery is really safe. It's effective. It is linked to some very, very small complications, but importantly, the benefits massively outweigh the very, very small risks associated with it. these treatments are absolutely life-changing. The biggest regret that people have when I speak to them is, I wish I'd have done it sooner. And, that is really the echoing message that I want to put across to you, that these are life-changing treatments for people. And I hope that we'll be able to offer this as much as we can, as quickly as we can, to our patients, certainly logged in this evening. The final message is, your expectations are key. You have to have realistic expectations, and that comes through engaging with aftercare, engaging with these types of webinars, but also engaging and reading and researching as much as you can, so that you know what to expect post-operatively. Thank you very much. So let's take your questions. Stevie, are you going to coordinate this? I'm going to stop sharing, yeah?
Yeah, thanks for that. That was brilliant. Do you want me to? There's many questions. I think you've really sparked some people's interest. Do you want me to ask the questions, or do you want me to go through them yourself like last time?
Right. So you are. So let's do this then. Let me go through the questions.
Yeah, no problem.
Are there questions regarding time frames and stuff like that you're going to?
I won't be able to answer the questions because the questions are all post kind of tier 3. So it's like, how long will we be waiting?
No worries. All right, let's just go through these. There will be some repetition, so please bear with me. So I'm still losing weight after my surgery, but is it true your stomach stretches more after time? So your stomach will never stretch back to the size that it was before, because these types of procedures are permanent, and it's just not possible. Certainly with the gastric sleeve, we're physically removing a large section of the stomach, and certainly the part that stretches is the part that we remove. However, the stomach is a muscular organ, and naturally it will relax with time. People often wonder whether their ability to eat more is due to the fact that their stomach has stretched. It's less due to the stomach stretching and more down to the fact that people's food choices might not be what they should be. They may be partaking in some of the slider foods that melt in your mouth and slide through the stomach more easily. And the second thing is, your gut does adapt with time, and your stomach will empty more quickly with time as well. So rather than it being an issue of stretching your stomach out, it's more to do with the fact that food, and certain foods in particular, are more likely to slip straight through the stomach and into the gut. Can you tell me when and if I will be put on for the list for bariatric surgery, and when I'll be put to tier 4? I can't really answer that question, but I do know that currently we are looking at a referral to treatment length of time of around 52 weeks currently. So that was 78 weeks. We've gone that down to 65 weeks, and now we're pretty much at 1 year from the time of referral to treatment. Is that accurate, you think, Stevie?
Yeah, I was just going to say, if you're in a tier 3 service, so that's More Life, ABL, any of the other providers that are local to the area, you're going to be with them for around 12 months. And 12 months is the minimum. Very often it can be between 12 and 18 months. And then you'll have kind of a bariatric review. At that review, we'll gather lots of information from you. You'll tell us all about your journey. And then that will be taken to the tier 3's MDT, so multidisciplinary team meeting. And then we will decide there as a team whether you are ready to be referred for surgery. So that's what will happen in the tier 3. And then, as Mr. Alfaf has said, it's about a year from that referral to being seen, isn't it?
Yeah. Perfect. Okay. What is tier 4? Okay, so let's basically go through the different tiers. Tier 2 is the GP's local service. They might have some dietitians that they employ within the practice. Tier 1 is universal approaches. So the government might have some local advertising to encourage people to partake in more exercise and eat more healthily. Tier 2 is the services offered locally. Tier 3 is a more structured program such as ABL More Life, whereby you have some more supervised weight loss an education and an understanding of why you have ended up in the position that you're in. And then tier 4 is pretty much the surgical service when you get referred on. So they're the kind of referral pathways. I need to keep scrolling back up to the top because it keeps taking me to the bottom. Bear with me. I have my 4-in-1 on the 18th of April. Good luck. Will I need a sleep study as I have a CPAP machine and have had sleep apnea for a good number of years? No, you won't. If we assess during the clinic consultation that somebody is at a high risk of developing or has a high risk of having undiagnosed sleep apnea, then absolutely you will need to go for a sleep study. If you've already got obstructive sleep apnea and you're on a CPAP machine, you just need to remember to bring that in with you when you have your surgery, but we'll talk to you about that in the clinic. Any questions for anyone thinking on going to Turkey for surgery? Okay. I've already done a webinar on this actually last year. So if you want a bit more information about that, certainly go onto YouTube and search for the session.
I'll post it in the chat now.
Very good. So the headlines are, look, I'm not of the ilk or the type of person that would criticize somebody for going abroad. These are life-changing treatments, and the price is a fraction of what can be offered here in the UK. However, the service is very, very different. The quality of the care is very, very different. And certainly if you go through that webinar that Stevie is going to post, there are some real dangers from going abroad. Even if you come back in one piece without any issues, and that will be the case for most people, you don't have any meaningful aftercare. In my opinion, aftercare and support is as important as the surgery itself. It is vitally and critically important to the long-term success in terms of weight loss and sustaining weight loss in the longer term. So if you can avoid it, absolutely avoid it. There's some questions for Holly here regarding her study, so we'll go past that. Time frames, we've talked about that. How long is a waiting list for surgery? So the waiting list is taking us the time for referral from tier 3 to tier 4. At the minute, it's 52 weeks. However, that can be delayed if you do need additional investigations or you need psychological support or additional treatment that might extend the time waiting. I can tell you, however, we are working really hard to reduce that waiting time as best as we can. And that's not just the clinicians, but also the operational managers. They're on our case all the time to try and put on extra lists to reduce the waiting times as much as possible. I am struggling, losing my 5% due to fluctuations with my colitis. Can I still be referred for bariatric surgery without meeting the 5%? The 5% is something which bears no kind of impact on the long-term success, and that's certainly not a criteria that we put on anybody on tier 4. It's something, I think, Stevie, it's something that is stipulated by tier 3, is it?
By the commissioners, yeah. So in order to manage the volume of people that might be referred for bariatric surgery, the commissioners have to put kind of some parameters in place to make sure that the system can cope with kind of the funding needs.
Yeah, and we've talked about this extensively before on other webinars, podcasts, and the bottom line is there is a lot of unfair rules. There is a lot of injustice in terms of how some of these procedures and treatments are offered. And they're made on a political level. These are certainly not anything that we have influence or power over. If it was down to us, we wouldn't stipulate that 5% because we know that it has zero impact on success in the longer term. But we can talk about that for 2 hours, and I need to get off my high horse and answer some of these questions. Can I have surgery if I have been in type 2 respiratory failure? Yeah, absolutely. You can, if you have been previously in type 2 respiratory failure. It's not that you have respiratory failure or that you have a medical condition per se. It might increase your risk around the time of surgery. However, what's key to understand is, what are we going to do to try and mitigate that risk? How are we going to optimize you? How are we going to make you as well as possible to mitigate that risk, to reduce that risk? When we offer surgery, it's always an option. It's always a balance of weighing up the risks and the benefits. We know for the vast majority of people, the benefit of having bariatric surgery is going to massively outweigh the risks of surgery, even if you have other medical conditions that put you at a higher risk. So let me give you an example. We quite often have people who have been diagnosed with cancer, who need surgery to treat the cancer. Well, we would offer them bariatric surgery in certain circumstances. People who are really struggling with type 2 diabetes and can't control the diabetes, well, in an ideal world, we'd want them to control diabetes before bariatric surgery, but in certain circumstances, we would proceed without it. People with severe cardiac history or heart problems, heart failure, people who have respiratory failure, if we believe that losing that weight and surgery is the only way to do that, is going to help them get on top of some of those medical conditions, then again, we'll consider it. But we have a multidisciplinary team which involves anesthetics, intensive care doctors, lots of people who help us understand how well or unwell a patient is. And very, very rarely do we ever turn people down for surgery. Now, having said that, the introduction of some of these injectable medications has totally changed the landscape of bariatric surgery and obesity treatment. We're now able to offer people some of these injectable medications for a period of time. So, for example, when somebody is really struggling with their weight and may have a body mass index of greater than 70 or 80, as I have a number of patients, what we would do is we would place them on some injectable medications with supervisions from the doctors, from the dietitians, from the bariatric nurse, reduce their weight, and then be able to offer surgery in a safer setting. Right. With the increased government funding for obesity, will this likely reduce the waiting list time? It's still over 12 months for the initial consultation. I can't really comment on the front end. The bottom line is services are still being cut left, right, and centre. And whilst there might be talk about increased government funding for obesity treatments, we don't really know where these are going. It's an election year. There's going to be lots and lots of promises. Whether or not that comes to fruition, I don't know. How do you know when you're chosen for surgery? So I think that's a tier 3 question, Stevie. Maybe
yeah, so it's not that we would choose you. You would be pursuing the bariatric pathway, and there are certain kind of criteria that you need to meet. So depending on where you live, there might be a BMI criteria, there might be that 5% weight loss expectation. We would look to assess your dietary changes and any lifestyle changes that you've made whilst you've been with us. So we'll be looking for things like reduced snacking, more quality nutrition in your meals, and more kind of rounded kind of plate, if you will. We'll be looking at your activity levels, your alcohol intake, any kind of snacks, sugary foods, that kind of thing. We'll just be looking at the changes that you've made as kind of on a whole, and that'll come from you. So we'll look at maybe your monitoring diaries and kind of all of the information that you've presented to us, and then from that we'll then take that to our MDT and make that decision as a team. So there's a GP in the room, we've got people from safeguarding, we've got therapists, we've got myself in ABL in that room as the bariatric lead. We've got lots of different people from lots of different specialisms that kind of sit around that table and make sure that surgery is it's the best time for you to have surgery, and essentially it's the safest time for you to go and have surgery. So that's how we make that decision. And then again, you've got that, we're a bit of a safety net really, because that's all done again in much more detail with the TFL providers and with the specialists and people that do actually do the surgery.
Very good. Just bear with me. Right. Next question. Can you still have surgery if you've had potentially past surgical complications? Yes, the answer is yes. But again, what we would do is we would tailor the approach to surgery. You may be less suitable for an operation such as the gastric bypass, which is more involved and requires surgery on the bowel. You might be more suitable for a procedure such as the gastric sleeve instead, and we'll talk about that in greater detail, certainly in our consultation. Does age go against someone waiting for bariatric surgery? Absolutely not. We do not discriminate based on age. That is at the extremes of age, whether somebody's young, a young adult, or in their 60s and sometimes even in their 70s as well. I've operated on people in their 70s in the past. And so long as we assess that the benefit that the patient is going to gain is significant and is going to significantly impact on the quality of life in a positive way, then there is no discrimination based on age. I've had 4-in-1, put on a little weight on between then and surgery date. Will the operation still go ahead if I put on a little weight? So a little weight is not a big issue. At the end of the day, you're having surgery because you've not been able to manage your weight successfully over many years and decades. And so that's not going to be the issue. You just need to be mindful that if you are struggling because you have been waiting, and we recognize that is a valid concern people have, to make sure that you do get in contact with the team. Certainly, if you've had your 4-in-1 already, you will have the contact details of the dietitians and the bariatric nurse. This is my second webinar. Okay, yeah. You need to make sure that the second webinar attendance is being documented. Stevie, that's for you to do. I've been diagnosed with Barrett's esophagus and intestinal metaplasia. Will it stop me from gastric surgery? No, it won't. However, what it will do is help us determine which treatment options are better for you. In my opinion, somebody with Barrett's esophagus and intestinal metaplasia, which is Barrett's esophagus, for people who are unaware, is a precancerous condition. Doesn't mean that you will develop cancer of the esophagus, but it's a precancerous condition which is often has developed or come about as a result of many years of exposure to reflux or acid heartburn from the stomach into the esophagus. So what I would say is that the gastric sleeve in that scenario would not be the first option. It would be the gastric bypass, a full gastric bypass, because that is the preferred option in terms of acid reflux and heartburn. Okay, Tracy says that she's under Fiona Lalu at St. Mary's. She's had multiple endocrine surgeries. She's been diagnosed with a pheochromocytoma, which is an adrenal abnormality. And one of the surgeons at Salford will be doing surgery before summer. Will I benefit from bariatric surgery? I'm a little complex, but I keep going. So if you are really struggling with your weight, then absolutely. And in fact, one of the surgeons who you're talking about here, Mr. Ran, has referred patients to me directly for bariatric surgery. And if somebody is waiting for really very major or important surgery, there are certain circumstances where you might be able to have access to an expedited or a fast track pathway in order for us to offer bariatric surgery to lose weight, to then make subsequent bariatric surgery safer for you. And we're seeing more and more of that. So certainly speak to Mr. Ran about that. We'd be very happy to consider undertaking bariatric surgery ahead of something else. But again, it's all about weighing up risks and benefits. If you are on a clock in terms of this subsequent treatment, whether it be cancer treatment, whether it be something like adrenal surgery or any other surgery, it's all about weighing up pros and cons. Someone's moving to the Fylde Coast. Nice. Already completed tier 3, accepted to tier 4. Will I have to start again? Stevie, that's a question to you, but I think once you've been referred, I think funding's pretty much secured. Is that right?
It depends. It depends on the commissioners. So there have been a few cases where people have moved from one area to another area, so in Greater Manchester, and we've spoken to the previous provider and got assurance of what's happened, and we've been able to do that. But in other cases, we kind of sent people's information and they've had to start again. So I think it just depends on your GP and the commissioners in the area. So if any of the local providers have got your information, I'm sure they'll fight your corner. But yeah, it's about just being in touch with us and your new provider and trying to kind of link us up to help make sure we can send everything over. But it should be fine. 9 times out of 10 it is.
Okay. I have a food addiction, which I seem not to be able to control. Would bariatric surgery physically prevent me from overeating? So when it comes to bariatric surgery, we always, regardless of who the person is in front of us, we always have to consider the factors which led to a weight gain in the first place, and they need to be managed and treated in the same way that you treat any other condition. So eating disorders, disordered eating, binge eating disorder, all of these things would really likely benefit from additional psychology support. You may need additional therapy. Some of that therapy would need to be completed before surgery takes place, because once surgery happens, we want to make sure that you're going to be focused, you're not going to be sidetracked or distracted by behaviors which then can jeopardize the results from surgery. So whilst it would, yes, absolutely, bariatric surgery would physically prevent you from overeating, what it won't do is take away some of those urges, and those urges can manifest themselves in other ways. Rather than overeating, you might then go and look towards overeating in other ways. So you might have more slider foods, and the type of food choices might be the wrong ones. So it's really important that if there is some disordered eating, that we examine that in much closer detail with our psychologists. And that's why our psychologists really play a pivotal role within our MDT. Right, another comment, which is Mr. Bjornsson, who is a strong man, has a BMI of 42.4, and you wouldn't call him obese. And absolutely, I mean, that's why BMI in and of itself isn't the most accurate of measurements. You have to bear in mind, however, that for 99.9% of people with a BMI of greater than 40, they are not of the same build as someone who is a strong man. And that's what we have to be open and honest with ourselves, that's the reality. BMI, having said that, BMI is a guide. It's not the be all and end all. It potentially does not take into account bone density, muscle mass, ethnicity. And that's why we don't just look at BMI, we look at other risk factors as well. The distribution of fat is also a key factor, is a key consideration. So if you might have a BMI of 35, but actually your fat is centered around the belly, it's what we call somebody who has an apple shape or central obesity. And the risk of cardiovascular diseases and serious complications in somebody with a BMI of 35 and central obesity may be much greater than somebody who has a BMI of 45 and 50, but their fat is distributed subcutaneously or under the skin around the bum and the legs. And so that person may benefit from weight loss surgery because it would improve their mobility from that perspective, whereas somebody with a lower body mass index would benefit from bariatric surgery because it would reduce their cardiovascular risk. So not everybody's the same. And I completely take your point that just because somebody has a certain BMI does not necessarily mean that they are of a risk of cardiovascular diseases. And that's why we do certainly take people on a person-by-person basis. Okay. Is surgery effective to people who have papillary thyroid cancer? So again, I'm not quite sure in particular. Are you asking whether it would reverse that cancer? It's unlikely to do that. But what we do know is somebody who has thyroid surgery to remove the thyroid would then be at risk of gaining weight because they wouldn't be able to produce the thyroxine. And people certainly with an underactive thyroid gland and low thyroxine levels are at a much greater risk of weight gain. And so there are benefits in patients with underactive thyroid for weight loss for weight loss surgery. Would having any of these medical conditions linked to obesity make my surgery any more likely, or wouldn't they make a difference in the process? So there are, I've touched upon it very briefly, David, that there are some conditions which may lead to you having expedited pathways or fast track pathways if you need very, very urgent surgery or treatment, which can only happen if you lose weight. But unfortunately, for the vast majority of people who have those medical conditions, that wouldn't put them on a fast track process. Given that you have to change your eating habits regardless if you want to lose weight, what are the benefits of bariatric surgery over standard lifestyle? Well, I've already touched upon that. It's all about the hormonal pathways and the gut pathways and the changes in appetite. And there's a lot of the mechanism by which these procedures work that we don't fully understand yet. But we are doing lots of research in that area, and we've touched upon that, so we can move on to the next one. What's best, the bypass or the sleeve? Quite often, when we talk about choosing the right procedure, there's often not really a best one. It very much depends on your set of circumstances, and we would need to go through that with you in clinic. So somebody who's had reflux and gastroesophageal reflux and heartburn, it may be better to go for a gastric bypass. Somebody who is young, who may be at risk of regaining weight in the future, well, I would probably, and somebody who doesn't have type 2 diabetes or other conditions like that, would probably think about a gastric sleeve, because once you've had a gastric sleeve, if you were to regain weight in the future, you can then go on to have revision surgery. But once you have a bypass operation, that's it. You're very limited in terms of longer term choices if you were to regain weight. So there are nuances to decision making, and there's certainly not one which is better than the other. Somebody who has hypothyroidism with underactive thyroid, we've talked about that. So will bariatric surgery make the weight gain stop? Yes, it will significantly not only stop the weight gain, but it will result in significant weight loss for sure. Okay, what are the tiers? We've talked about that. There's a lot of questions about waiting times and referrals, which we've talked about that. What are people volunteering for? So that was with regards to some research that was presented, and we'll get Holly to represent it at another time. Tier 3, type 2 diabetic, fatty liver, struggling, losing weight, but not significantly. Would I be eligible to have an operation quicker? It's causing a lot of stress and anxiety. I mean, certainly based on what you've said, unfortunately, wouldn't put you at on an expedited pathway. If you imagine, in an ideal world, I'd have everybody on an expedited pathway. I'd have everybody have their surgery, in the next month if I could. But we do live, unfortunately, in a system, or work within a system which is rationalized, and there are limits to what we can offer. Now, there's benefits to that, of course. It means that people do have access to these treatments without having to pay for them. And in other systems where people have to pay for their treatments, of course, that they will be able to access that a lot more quickly. Can bariatric surgery be expedited if you're waiting for gynae surgery? Again, it very much depends on what type of gynae surgery. If it's gynae cancer, then yes, potentially we can. Keeps jumping back up here, Stevie.
I think every time somebody asks a question, it moves the thing down.
Right, no more questions. There's 210 questions here. So what I probably would do, Stevie, is once we get to our limit, is there any way of copying all of these questions down?
Yeah.
And then what I could do is do a separate recording for people to have access to, like a Q&A.
Yeah, that'd be fantastic.
That might be a better thing. Hang on a second. Oh, there you go. I've copied and pasted that there.
Yeah, I can pull it all off Zoom. So I'll just pull a report off and can send it over.
Is the endoscopic balloon an option through Tier 4 at Salford Royal? The answer is probably not. In some circumstances, the balloon can be used as a bridge to further bariatric surgery, but the balloon will only help you lose, on average, 1.5 to 2 stone. The vast majority of people that we offer surgery to need a lot more weight loss than that. And in fact, what we have found certainly is the injectable medications will offer you very similar levels of weight loss to the balloons, which are associated with a whole host of complications, intolerances, etc. Okay, so the answer is no. Will weight loss injections ever become available on the NHS? Yes, they will. They already are available on the NHS. They are absolutely rationed at the minute. But what's key to understand is that they are not a magic bullet. If you have a BMI of greater than 40 and 50, they will not result in the weight loss that you need. Again, it's about having realistic expectations. There's a complication, not complication, but an intolerance profile as well. And as we begin to use more and more of these injectable medications, we're beginning to see some of the longer term effects. We do know that once you stop taking the injections, for a lot of people, they regain the weight that they lost. So in terms of long-term sustainability, it's probably not at the minute where it needs to be. And it's certainly nowhere near in terms of a comparator to bariatric surgery. I had my sleeve nearly 6 years ago and lost over 9 stone. And I can't lose any more. I'm still at 20 stone. Would the gastric bypass be possible for me on the NHS, even though I've had a sleeve gastrectomy? Well, the answer to that very much depends on the commissioners and what type of surgeries are funded. I don't know where you've had your surgery before, but in principle, having further revision surgery from a sleeve to a bypass is absolutely possible. Okay. There's your stomach stretch. We've talked about that. I have BMI of 61.5, severe asthma, severe reflux, sleep apnea, hiatus hernia, can't move because of my weight. I'm breathless. I'm on loads of different medications. I've still not been allowed to access bariatric surgery. Well, I'm sorry to hear that, but you would be absolutely somebody that we would want to help. I'm not quite sure if you're on tier 3, Stevie. The fact that this lady is on this call, that must mean she would be a candidate.
Not necessarily. So I think myself and Jodie felt that this platform was really valuable, and because lots of people were going abroad for surgery, we felt a duty of care to let as many people gather, real, truthful, trusted information from somebody like yourself. So we shared it wider, but it is likely that the people here are probably on tier 3. But I mean, if they can send me a message privately in the chat, I can have a look into it.
Yeah, absolutely. Time waiting, we've talked about that. Automatic eligibility. Right. So I've talked to you about, so the question here is, what does automatically eligible for bariatric surgery if your BMI is greater than 40? So we've talked about what NICE guidelines say, and I'm afraid not every region is governed or uses NICE guidelines, and some regions and commissioners absolutely do place restrictions on who is offered bariatric surgery, and that's down to rationing. That's down to the fact that we live in an environment and in a country which has limited resources in the NHS. So whilst I stated that BMI of 40 or more, it should make you eligible, the reality is that might not be the case if you live in a region where the criteria is slightly different. It's a bit unfair. Well, it's very unfair, but that's certainly a political and a rationing decision-making process. Why can't we get Saxenda? As we're told, it would aid and assist weight loss in the program. I know people have brought it privately from reputable sources online. Yes, it's still heavily restricted. There's supply issues for sure. And it's been used up quite heavily in the private sector. Now, that's not a reason per se as to why we can't access it. I'm sure the there's many factors, including the pharmaceutical companies not making it at a quick enough pace. Again, we can get into political discussions here and conspiracy theories that we want to avoid if possible. Okay, that's a logistical issue. Is there any type of bariatric surgery that is or isn't recommended for someone with ulcerative colitis? We would generally avoid the gastric bypass because we do know that inflammatory bowel disease can be flared up by surgeries on the bowel. So we would probably think more along the sleeve gastrectomy. My BMI is 48. It was 58 when I was referred. If it drops below 40, will I be discharged? Stevie, that all depends on the criteria. Certainly from my perspective, that would not be an issue.
No, nobody's penalised for losing weight. It's if your BMI is at the criteria when you start, that's absolutely fine. And you're encouraged to lead a healthier lifestyle. And, you know, the kind of the benefit of that is that we might lose some weight. So no, that's absolutely fine.
Okay. Next question. Am I an advocate for stomach balloons? Look, all of these treatments have their place, but what we must keep in mind is, what are we trying to achieve? What is going to be the outcome from a gastric balloon? And that's not what you're going to be promised, but it's something that you need to be looking at more closely in terms of what is the data, what is the research, what is the evidence out there. And the reality is most people will lose 1.5 to 2 stone with the balloon. And when the balloon comes out, most people will regain the weight that they've lost. If you're somebody who has really struggled with their weight, their BMI is over 40, they've struggled with their weight for many years, the reality is that a gastric balloon is just not going to cut the mustard. And therefore, a longer-term solution or longer-term tool is going to be required to help you with your weight loss. Now, that's my personal opinion. That's certainly the opinion of many surgeons and many doctors within this field, that we need to fight fire with fire. If you have struggled for 10, 20 years, then a balloon that you place for 4 to 6 months is just not going to really make the changes that you need. But I completely understand why people buy into the idea of a gastric balloon. It is a lower risk procedure. It is reversible. It gives them the sense that they're still in control. But the bottom line is that the longer term results are certainly nowhere near the more invasive surgical options that we have. Here we are. Waiting time. Does everyone need to have an endoscopy before sleeve or bypass surgery? No, it's selective. So an endoscopy is a camera which we look down into the stomach. If you have a specific reason to have an endoscopy, then we will certainly arrange that for you. But the vast majority of people do not need endoscopies. Will I be able to have bypass considering I had spontaneous pulmonary embolism before? Yes, you will. We just need to manage your risk of developing clots to the lung and to the leg in the future. And that's something, again, I treat patients quite regularly who have had a history of deep vein thrombosis or pulmonary embolism or clots. And we have a pathway and a protocol that we use for those types of patients. Does everyone need a psychiatrist appointment? So psychology appointment is not necessary for everybody. If we assess your risk of needing psychological support at the time of surgery, at the time of your appointment, and certainly that's also assessed in tier 3. So quite often people come to us with a tier 3 recommendation that they should have psychology assessment. We will certainly take that into consideration, but certainly not everybody needs psychology support. I'm on the moving on groups now. My BMI is 43.5. I'm pre-diabetic, fibromyalgia, and I'm really struggling losing weight. Am I still eligible for either injections or surgery? Yes, absolutely. You would be eligible. Lots of questions about waiting lists. Gallstones. This is the first time someone's asked me about gallstones tonight. Gallstones are it's a very common concern and fear that people have. Around 1 in 5 people will develop gallstones. So that means the bile, which is produced by the liver, it crystallizes into little stones in the gallbladder, which sits under the liver. We think between 1 in 10 and 1 in 5 people will go on to develop problems with gallstones. And if that is the case, then you would need further surgery, keyhole surgery, to remove the gallbladder. Gallstones can occur with anybody who loses weight quickly, and a significant amount of weight as well. Excuse me. What happens to the unused stomach? Does it die, rot away, or just remain? So that's in relation to the gastric bypass. The gastric sleeve, we physically remove it. We send it off to the pathologist to look under the microscope to measure it up and just to have a record of that. For the bypass, it absolutely stays in place. It does not rot away. We do not remove any of the blood supply to the stomach which has been bypassed. And in the very rare circumstances that a bypass needs to be reversed, it is possible to reverse the bypass, although the anatomy never truly returns back to its original form. How do you know which surgery is right for you? Well, there's a whole new there's a whole different conversation that we need to have about that. Perhaps we can do that on another webinar about how do we choose between the different types of surgery. But the bottom line is that we will talk to you about that in a lot of detail anyway during your consultation. Okay. Can we be sent a copy of the slides? Yes, you can. It'll be available online, I think, won't it, Stevie?
The video will be online, but
Yep.
the slides, as you have them, won't be. So if you want me to put them in a PDF and send them out, can do.
But the video at the beginning of the slides will be available online, won't it?
Of course, yeah. So that'll be on YouTube, and I'll share it on the Facebook Bariatric support group as well. That kind of links in with this webinar, and
Okay.
I'll put the link in the chat if nobody's joined that yet.
The mini bypass, what happens to the part of the stomach that's not being used? We've already discussed that. Deborah's asking, her BMI was 79, it's now down to 53. Have I got any tips? Well, hopefully, if you're waiting for bariatric surgery, then absolutely that's what you should go for. We've talked about excess skin already during the presentation. The answer is the vast majority of people will not be eligible for removal of excess skin on the NHS. And I've already given you some advice about how to choose a plastic surgeon if that's what you want to go and have done. Recovery time once you've had surgery, and also somebody has an umbilical hernia or a hernia around the belly button. Most people will need 2 weeks off work. Again, it depends on the nature of your work. If your job is strenuous, involves lots of heavy lifting, then you may need longer than that. If your job is very sedentary and involves you sitting behind a desk, you will need less time. And certainly what I find is people who are self-employed are far more likely to get on and recover more quickly. Now, if you have a second issue, such as a hernia, belly button hernia, that shouldn't impact on your ability to have bariatric surgery. But quite often I'm asked, can you repair it at the same time? My preference is absolutely not, because we know that the risk of the hernia coming back again in the future is greater if you are still overweight. So we wait until you lose weight and then you go on to have any additional surgery, such as hernia surgery. We know that every subsequent time you have hernia surgery, the risk of the hernia coming back increases. That's why if this is the first time it is being repaired, then do it once you've lost all of the weight. That's better. Someone's had the gallbladder removed. Can they use the same incisions? Well, it very much depends on where those incisions were. I personally like to use the same incisions just from a cosmetic perspective, but under no circumstances would we compromise the safety of performing the procedure by trying to use the same incision. So it's a balance. We might use some of them and we might need to use new ones for the other incisions. Okay. How long do you need off work? We've talked about that. What about medicine after surgery? I take a lot of painkillers plus medications. Yes. So that will be a consideration. So there are some procedures such as the bypass that might impact on your ability to absorb some of the medications, and some medications will need to be changed, certainly in respect to the doses of those medications. And that's why if you've got specialist care or have a specialist team looking after a very complex medical problem, we regularly engage with them, and it's important to let them know that you are having this type of surgery in advance so that they can prepare themselves for changing doses to some of these medications. Someone who's a wheelchair user with damaged spinal cord, will this make a difference? Of course, we have to be realistic here. It's as much about tailoring the approach. I'm using broad principles. I wouldn't expect you to have the same levels of physical activity as somebody who is more able-bodied, and therefore we would need to tailor your physical activity. You should still be, if you have the use of your arms, unable to do some upper body exercises, then absolutely that should be encouraged. Is there any help for after the surgery for keeping it off in the long term? Absolutely. Aftercare is key. We offer at least 2 years of aftercare in the NHS. That's what is paid for. I suffer with keloid scars. I'm nervous about the scarring. Would you advise against the surgery? Again, it's all about pros and cons. What is the benefit and risks? Is the risk of you developing keloid scar, is that a greater concern for you than the benefits of the operation, of the significant weight loss and the reversal of your weight-related medical conditions and your improvement in your mental health and your quality of life? You're seeing where I'm going with this, don't you? So I think in terms of keloid scar, there are things that can be done to reduce the impact of keloid scar. And for those that don't know what keloid is, it's the overgrowth of the scar, and it can look unsightly. But it's about weighing up risks and benefits. Nobody should ever be telling you that you won't get a keloid scar. It's about having realistic expectations and weighing up the pros and cons. Okay. So we're at 8 o'clock now, and we're not even a third of the way through the questions.
You've done very well, though. You've got through a lot of them, so well done. I'll pull those questions off, as I said, and I'll email them across to you. And if you are willing to do that video, that'd be fantastic.
Yeah, let's do that.
And then we can share it in the next webinar or whenever you've managed to do it. I think on behalf of everyone, Mr. Alkafaf, I'll say thank you. That's been really informative, and your videos are always well received. I'll share this video once it's been edited on the YouTube, and then from the YouTube channel onto the Facebook group. As I've said, I've shared the link to the Facebook group so you can have a chat amongst yourselves, offer any peer support if you want it there. And there are some smaller chats that people have made themselves to discuss various things. So there are lots of different conversations going on. I do think people find it helpful. And otherwise, if you haven't yet done so, please fill in the Survey Monkey. That'll mark your attendance at the session tonight. So brilliant. Thanks very much.
Thanks, everyone. Have a good evening. Take care. See you soon.
Bye. Bye-bye.